All right, well, welcome back, and I think we've got had a very exciting number of presentations this afternoon, and I think really importantly addressing some of those really critical non-seizure outcomes that are so impactful on quality of life. And so I'd like to encourage anybody from the audience to come forward with questions. We are going to have our panel here, but we also, I understand, will have some of the moms who talked about their experience with LGS. If there is a specific question that we need caregiver input, it would be really wonderful if we could get some input from other people. So maybe I'd like to just start with, and we'll just maybe start with you, Ingo, and go forward. What do you think really are the core non-seizure outcomes that we need to be measuring in LGS?
Oh, that's my microphone. So I think we kind of talked about this during the break a little bit. When we think about the different domains, I think what we're kind of struggling with, I think seizures is the thing that we understand, and the reason why we, in a way, exclude this already from this discussion is because we know what its limitations are. I think that the next challenge is going to be development, and especially the issues we heard earlier about how can we use kind of scales out of the age range, how can we define, break down development into different domains, and then behavior is going to be the real challenge.
I agree. Thank you.
I think I would agree. I think beyond, to answer the same question,
please. Yeah.
Beyond seizures, I think I'm guided by what parents tell us, not just in our preliminary data so far in our own survey, but lots of other conditions and functional abilities, particularly communication is critical, and we need to be able to measure it, and if it maps to the mechanism of the medication that's being tested, then absolutely that has to be there.
Thank you.
I think the question, and Jenny, you alluded to this, has to be answered by the parents and caregivers, and we don't decide for them. That is the first ethos ethic to change in this whole discussion. What I have heard, but it has not covered the full range of things, is that communication is so important, and not whether you can stand up and give a talk at a meeting, but can you tell me, my child, are you in pain? Are you hungry? What do you need? But I think we need to get that information from the parents. And I just wanted to make a mention too, most of the individuals with Lennox-Gastaut syndrome, they start off seizures early in life, but you know, the LGS itself does not manifest until later. And we need to stop talking about just development. That's something that's a concept that is good up until about the age of 5 or 6, and then we start talking about impairment. And I'll have some other comments about that later, but we really need to change the dialogue on that, I think.
I agree. One of the big things and the themes I thought was translatable for the work that I've been involved in is one of the most earliest delays that we see is in communication, and language is so critical. And we're seeing this as the epilepsy emerges, and then tracking the development along the way. So I think to realize and recognize that as early as possible is very important.
I think all those responses have been excellent. I'm not sure if I have a whole lot to add. I agree, communication is certainly what I hear most from families. I've really been moved today by the challenging behaviors that kids with LGS exhibit, and think that that's something that we really need to be thinking about and addressing.
What they said.
All right.
But yeah, I mean, we have to listen to the families, and the behavior piece is huge. And I think, you know, as a clinician, there's really not a lot out there that's appropriate in terms of measurement of behaviors, and there's not a lot of description of the behavioral topographies in these rare conditions. And so I think there's a lot of room for growth there. So.
Can I just get the input from the families? So for families, do you, I'd be really interested to hear, is there sort of, you know, one aspect that is most critical, something else that is maybe also critical, but perhaps a little bit less?
For me, it's for us, it's the challenging behaviors. And I'd also like, in my opinion, I'd like to argue too that the communication and challenging behaviors could even go hand in hand. so if my little boy could communicate better or, really be able to process and get out what is going on, that might mitigate some of those challenging behaviors as well. So
I think that's a great point. Thank you.
Can I add? Sorry.
I talked about behaviors because I was asked to, but I did have to cut a few things from what I talked about just for time. But sleep is huge for us. My son is doing a lot better, and it has to do with the quality of the sleep that we've been able to get for him, and that's been better than any other thing we've tried, any therapy. So I think just finding that connection between sleep and seizures, sleep and behavior, sleep and all of the other things that affect the brain is super important.
Yeah, and we know that those are often intertwined as well, right? Thank you. Sorry, you can go.
So I want to make a point that is maybe a little controversial, so I want to make this very, let's say, stringently. Yeah. I think what we have seen when it comes to disease concept models is that we have to distinguish between these symptoms, the impact of these symptoms, and the impact on the caregiver. And the way I kind of think about this is that when we think about behavior or development or impairment, that we also using these terms very, let's say, imprecisely, because the question is this reflecting the disease severity that is modifiable by a potential treatment? Or are we looking at the, let's say, impact of a certain disease severity in the setting of a certain family setting? And the later one can be quite different, of course, in the setting of what the resources are or what the family structure are. And maybe this is just a point that I wanted to make, that we have to think about in which domain this actually falls, given that this is kind of increasingly difficult to really measure in trials, the kind of more we move away from the symptom itself.
Thank you.
I just wanted to add, I am a little guilty to say this, but as I said when I was talking about my son Mason, he has been seizure-free for almost 8 years. But as you can see, and while we know every day how lucky we are, every day I'm waiting for them to come back. It doesn't go away. I know today could be the day, tomorrow could be the day. I don't take a single day for granted. Having said that, many things improved when the seizures subsided. Most things didn't. So yes, seizures are the #1 goal, and they were for me too, but like I said, he's still been robbed of almost everything a human being should be able to do, even though he's not having seizures. So I just wanted to put that out there.
I think that's a really important component. So in epileptology, we talk about this developmental versus epileptic encephalopathy. And so the developmental encephalopathy is sort of the challenges in development that really come from the underlying cause, right? And then the epileptic encephalopathy is the additional challenges that are caused by frequent seizures and very, very abnormal EEG. And I think the challenge is for many kids with developmental and epileptic encephalopathies, it's a combination of both factors that are contributing to that. So as you say, sometimes we see improvement in seizures, yet there's a lot of other stuff that doesn't improve. And so how do we manage that? Thank you. Jim, I think you had a question earlier. Yep.
Oh, I just was going to add, whenever you were talking about parents and other potential things that we would see, is that systems are not designed to support our children. The Vineland is something that we would never be able to navigate. I mean, we're going to go to the floor on that one, but then this we would not be able to qualify for because my son is mobile. And when we tried the QR code, it asks very specific questions before you can continue through that survey, and it's being mobile or being able to not be tube fed. And so because he qualifies that way, but cognitively he has a 40 IQ and is so profound that he can't feed himself, it's like, where does my kid fit if he doesn't fit anywhere? And we see that all the time in ERs too.
Thank you. I think that's one of the challenges, and how do we measure these non-seizure outcomes? Because again, there is a fair bit of fluctuation between the different kids. Thank you.
I was just going to comment that, we talked about several of the parameters the Inchstone project is looking at. I was going to ask our neuropsychologist, but What I did not hear is any Inchstone project to look at the disruptive behavior, which seems to be overwhelming to a lot of our families. And I mean, I hear all the time from my families that are kids that are seizure-free or almost seizure-free that, you know what, they wouldn't mind having a seizure, you name it, once a month if the behavior was better, or if they slept better, or whatever. They'd almost, you know, it's just trade, we'll trade this, you know, if we're bartering with God, we'll trade these things, you know, kind of thing. And, you know, I think that's, you know, a critical one. Some of these, I get it, are almost easier, like fine motor, gross motor. I think you could almost develop an AI program to, you know, parents could upload videos and they could say, okay, we can rate that. We don't even need a human being for some of those because that's already there with seizure detection in sleep. I mean, there's so many movements that have been characterized in normal infants. So it's the other stuff that I think it's going to be much harder to kind of address.
That's a really interesting point, Jim, but I think some of the disruptive behaviors that we heard about were extraordinarily disruptive. Those are not Inchstone type issues. And if we were to, and we have behavioral specialists here, if we were to go to the literature, I suspect we would already find some, if not entirely fit for purpose, more fit for purpose measures. The problem that we run into, and that's why I tried to say the comments I made did not really reflect what was going on with Crystal or Andy's boys, okay? But we see people take, for example, the aberrant behavior checklist and ask those questions of a child who is immobile, can't use his hands, is fed by a G-tube, is completely nonverbal, and has CVI. And that child can have disruptive behaviors, but they don't have anything to do with walking across the room and hitting his sister, you know? It's a very, very different kind of behavior, and that's why we really have to understand what is the concept of interest, what is in detail, and there may be a couple within this group for those who are mobile and able to hurt their parents to those who really can't do too much but still have behaviors.
I was just going to add, like, I think it's a huge gap. I don't know how many measures there really truly are. I don't know, Mary, if you know of any, but like, I think a lot of the extant measures have significant limitations. However, behavioral psychologists as a discipline are really good at capturing behavior on the individual level. I mean, you know, if you speak to folks, my colleagues at Kennedy in our behavioral unit, I mean, they are having their eyes on these kids and tracking every single behavior moment by moment. Right? And so there's a real, like I said earlier, I think there's just so much room for growth within, you know, these rare conditions to start to look at those methods and apply them to these populations in a meaningful way for clinical trial readiness as it relates to disruptive behaviors. So I tell my colleagues all the time, I'm like, let's do this together. Come on, like, join the party, you know? Because I just think that there's so much room for growth. Did you want to add anything, Mary?
No. Okay. I agree. We were just chatting.
We were talking about that, yeah.
I'm Crystal Ferguson. It's a clarification question. I think it was, I'm wondering if you were saying, I can't remember, I don't know your name, I'm sorry, in the plaid shirt, doctor? Yes. Okay, Dr. Ingo, that the behaviors seem to be more differentiating between the effect of the behavior on the kid versus the parent, that maybe it's more disruptive to the parent but not the kid?
So I actually wasn't saying this, I was asking this. And I think I was just kind of asking whether we talk about the same thing when we talk about behavior, because I think we might get into issues trying to understand what is happening. I think at the point that you made about this kind of individualized behavioral assessment is important, that the behavior is quite individual, yeah? And I think it's important to differentiate between what is the actual behavior and what is the impact of the behavior on the family. We've heard earlier that there are some situations when seizures get better and then the behavior gets worse, for example. So I think this is just a very unexplored territory. And then the question is how much of this is really fit for trial, and how much of this can we really translate into a measure that is stable, that somewhat reflects the severity of a disease, because we know that behavior can fluctuate.
Okay, because I just wanted to clarify, like for me, for me, the behaviors that we're talking about, it is very obvious that the child is in a disruptive neurostorm. It is impacting them. Even if they were in a room by themselves with the door closed, they are going through a very difficult, time. So I just don't want it to appear as if it's just, oh, this is just irritating to the parent. Like, this is definitely.
We hear ya.
I think this is exactly the point where you can say behavior, but this is what I mean.
Okay.
Yeah, and I think this is often that we have to take this word and just split this apart into what the kind of different aspects are. Yeah?
Hi. One thing I did want to sort of talk about the power of clinical trials or researchers versus clinicians is a clinician's office isn't often a safe space to talk about some of this stuff. And to your point about impact on caregivers could be different if you're from a family with flexible jobs, flexible bosses. Reporting things like sleep issues might not be, I can say as a kid with a kid with a different syndrome who doesn't sleep 5 nights a week, we were kind of gaslit by our clinicians that because she wasn't waking up, falling asleep during the day, it wasn't an issue. And honestly, we were rich enough to acclimate and bring in help so that we did not push forward with this until she got a genetic diagnosis that explained it. But single parents often don't have that support. And so even just the power of asking the question about things like sleep, and the same with behavior, which is if your kid has pushed you down the stairs or is exhibiting really violent behavior, that someone would see with a video that it's a real issue, but the risk of showing that to someone and having social services brought in is just that it's a very real thing within your house, and also you're dealing with the fact that, oh my God, my kid just pushed me down the stairs. So even just the power of asking those questions within a survey, making it a safe space for parents to actually share that it's game-changing for us, and clinicians in 15-minute visits just often, they don't have a soul for it to start with. And you just sometimes, even with clinicians you love, it's not a safe space to share. So I just wanted to put that out there, that even if the impacts are really different, I actually think based on what a household looks like, but also the power of asking that question is so real, especially for things like sleep and violent behaviors.
I think that's a good point. And I think one of the things with tuberous sclerosis, and maybe I'd like Martina's thoughts on that, the tuberous sclerosis, the TAND checklist. I think just looking at each of those and asking each of those questions really helps us make sure that we're asking about some of the other important things as well. Is that something that we need to be incorporating for LGS?
It's a really good question. I think with Petrus de Vries, who from South Africa developed the TAND, and it's really, for clinicians, it's a really good reminder that you need to go through those series of questions. There's 6 aspects of the neuropsychiatric dimensions of TSC, and touch on at least all of them during every visit. And a lot of times, and then it becomes just natural that you ask those questions. And now there's actually one that you can do online, and they've there's a quantitative measure, and so it can be scored. It's called the TAN-SQ, so you can take a look at that. But because 10 years ago with TSC, people weren't addressing the neuropsychiatric aspects of the condition. It was so concentrated on the seizures, and from the parents' voice in working with the Alliance, it became much more front and center, and also doing a natural questionnaire for the parents in the community. The behaviors are almost and sometimes more important than the epilepsy. Mm-hmm. And we know we're learning more and more and more about the evolution of the epilepsy and where the behaviors come in, and then also the development, and you can kind of follow that, those different symptoms.
Thank you. Tracy.
This is Tracy from the LGS Foundation. So I wanted to make 2 comments that were sort of validating on the behavior and sleep questions, and then I have a question for the panel, and I'll be quick. So sleep is interesting. So when we first started talking about sleep in the field, and at first we were talking about sleep, and then everybody sort of gravitated to, oh my gosh, we have to like now give sleep drugs. There are sleep problems in the DEEs. We got to give melatonin. And what about CPAPs? Everyone's got to get a CPAP. And then we quickly, I think we overthought it as scientists, and this is one way where I'm in here, but then we quickly started talking about the whole family. And oh my gosh, the siblings are co-sleeping and the parents aren't getting any sleep. And there's a point where I was at the hospital or at a medical appointment with my daughter with her pediatric epileptologist, and he was asking me how I was sleeping, which I appreciate, but I'm not his patient, right? And so, and I think that as for the pediatricians, especially in the room, that it's just your nature to try to take care of everyone, right, and everything. But when we get to a research study, we really have to define this stuff. What's impacting the family? What do I have power over? And and then okay, great. It's great if you can find somebody who has epilepsy and apnea, but a lot of our kids won't tolerate wearing or even being tested for apnea, right? And so then it starts to get more personal. But then on the behavior side of it, so Savannah was functioning at about a 3-year-old level. She didn't read or write. She could barely get her words out. She was sleeping 18 hours a day at the age of 18. And then the seizures dropped and the status dropped, and she started to grow again, and her speech just took off by leaps and bounds. But we had to deal with behavior that she had never learned before, that you can't lick people, right? You can't take off your clothes in public, right? It's the stuff that she never learned. And so there was an element of, she just never got this because she had so many seizures, she never got a chance to learn. But then there was the stuff where she doesn't have any context for that behavior, right? So, it's one thing to say, well, you never learned to take off your clothes. It's another thing to say, why? Right? Why can I not take off my clothes, right? Which she never reached that sort of level of cognition. And so, and then you also just have, she would have behaviors where she couldn't get the words out. And that sort of likens back to a typical 2-year-old in my mind who doesn't have language, right? And has nothing to do with the seizures getting better. But then you also have these instances where they just go all, it's on with you, right? And so that was sort of a different level. And so I differentiated these different levels of behaviors, and we lump it all together as patient families, and maybe in the clinician's office it all gets lumped together, but when you want to do a study, right, then you really have to dissect this out. So who are we treating? How are we measuring it? Because we're all going to have to answer to Michelle over there from the FDA when she wants to know how we're measuring it, right? Just kidding, Michelle. And then the one question that I have is the same question that I asked the last panel. So you guys all listened to how we are doing LGS trials now, and then you talked a lot about the really cool stuff that you're all doing in spaces outside of LGS, next to, peripherally, very close to, very important, very related to. But what can we do, the people in this room, to advance LGS and or DEE trials in general, if that lumping sort of trial type effort works? What can we do today so that 3 years from now, 5 years from now, we are not doing the things the same exact way we're doing them today? And what would be your recommendation from where you sit, having heard what you heard this morning and knowing what you know from your domains?
Tracy, that was a lot to respond to, but I want to respond to your first to your 2 comments about the pediatrician asking how you're sleeping, and that his or her job is not to take care of the parent, but realize that you're the person taking care of the patient. So being concerned about you is appropriate in a way. And I just want to point out that when we had the SCN2A meeting in July, there was a whole session for caregivers that Leah Schust and Carla Forbes put together, and it was called Taking Care of Yourself is Not Selfish. And I think that's a really important that's an important message for every parent of a child who's challenging for whatever reason. So please remember that. For everyone, for everyone, but I think the burden of taking care of a medically complex, neurologically complex child is overwhelming, and it's something it's really easy to forget. So please don't forget it. In terms of the behavior, I mean, this is something I'm starting to struggle with a lot, and I'm not specialized in this area, but we keep using markers of behavior and saying, well, my child's like, at the developmental level of a 2-year-old. That's just an approximation. And, she's 30. And she's got, some hormones going through. I remember watching her and Adam dancing at the LGS meeting thinking, we got to be careful here. We don't know what, we just, and right, exactly. And so we have to be really, again, we have to reimagine what is this behavior, because it hasn't followed the same trajectory as a typical individual. And now we're patching in all this other stuff. Like if a 2-year-old strips in public, everyone goes, tee, oh, isn't that cute? A 30-year-old, not so cute. That's a real problem. Or who is it? Was it your son? No, wait. Whose son ran down the street naked? Yeah, right. That it's really cute when your 2-year-old does it. Your adult child who's at a 2-year-old level doing it's not socially appropriate. I don't know how we deal with that. But we need to realize that we're dealing with the fractured development and things do not fit together in the same piece. I'm sure other people have lots to say, but in terms of where to go next, and it may just be that I'm an outcomes person, but I think you need the outcomes to figure out where to go next. And I know you're planning a natural history study, and I think if you could focus in on not just what's important, because I think you're all very articulate about that, but really getting into what does that mean? What is the behavior? What is the communication? You identify your domains and really do that deep dive and then start to figure out what your measures are. It'll be a huge, huge, huge leap forward. Okay, I'll stop talking, sorry.
I'd second that, absolutely. And I think the understanding of what a domain looks like that is impairment related, not just developmental delay, is critical. And we hear that when we talk to families, and this is CDKL5, but they talk about not just my child shows happiness or upset, but they show a whole range of other emotions as well and can describe examples that explain what I would see if I was there. They don't just choose yogurt or cheese, they have a preference. There's more to all of the aspects of communication. There's back and forth, and it might not be, hello, how are you? I'm very well, verbally, but there might be blowing games, backwards and forwards with somebody else, or, something like that. So there's lots of levels of communication within the fundamental domains that we actually need to tap into for these children, because that's a great place to be doing that with your dad, if that's a gain in skill, and you wouldn't want to lose that if there was some harm, some adverse effect. And the second thing is I would like to reiterate the point that Dr. Campbell made earlier, that what is critically important is that we understand what a small, meaningful change would be. And we have started that with SCN2A families, and it has been incredibly important for sort of the growth of our understanding of the idea of a whole range of change-related concepts. So we want to know how reliable a measure is, so what change is beyond the random noise. And then we want to understand what would be meaningful for a group, but we also want to know what would be meaningful for individuals, and how exactly we do that, I'm not quite sure, but we need to ask the question of families. If you're doing a natural history study, include questions like that so that you can start to collect that sort of opinion that you can map to children of different abilities or different domain scores.
Any other input from, yeah.
Tracy and I have talked some about this, but I think to understand, doing the natural history is very informative and very valuable, because it gives you kind of the foundation, and from that you ask questions, and then you develop strategies of how do you answer that question. And I think just from my own personal experience, that's very much what happened in TSC. And I think just when you start doing studies that are funded, having a uniform platform, having consistent translatable data, that you do it consistently over one study to another, so you build on the foundation of the first one and then can go back and answer questions. So you don't try to change the format, you do as best you can to get it right and thorough and collect as much data as you can, and because you may not think of a question till 2 or 3 years later, but then you have the data to answer it. So really be bold in what you want to think about and potentially what you can answer, and try to be as broad and comprehensive as you can in terms of the acquisition of the outcomes and the data that you collect.
I'm a both and person. I find this like helpful personally in the sense of like dealing with, a complicated world, but the idea that two things can be critical or important at the same time. I think clinically, I see a lot of young children and there's so much focus on seizures, which of course there should be. As a psychologist, I suppose I have a bit of a personal or selfish interest, but I think sometimes I hear talk of waiting until the seizures are better under control to deal with issues like development or behavior. And unfortunately for so many kids, like that doesn't happen. And then there's, months or years where some of those needs have not been addressed. And so thinking about like clinical trials, obviously focusing on seizures, but also appropriate measures of behavior, which is like what I've been like slammed with today, in positively, but really thinking about how we can focus, especially for kids with LGS or kids who we know are at high risk for delays in functioning and behavioral issues, really starting to think about what interventions or assessments that we can use to get ahead of that. One of the things I was taught by one of my mentors is that you get better at what you do, or you become what you practice. And so the longer that any of us spend time doing something, the more we keep doing it. So if there are ways to make sure that we're assessing early, but also intervening early on some of these non-seizure outcomes or comorbidities, I think could potentially, hopefully, reduce those challenges for older individuals. Obviously, like behavior strategies aren't gonna remove LGS or like genetic conditions, but certainly having skills and strategies to manage some of those comorbidities, I think could be helpful. And the earlier those things are started, the better.
So we've talked a lot about, and I think we all recognize the importance of measuring the non-seizure outcomes. So in clinical trials, when is really the most, like when should we actually expect those to be present? So most of the clinical trials we're doing are kind of 3-month trials. Is that long enough? Should we make this a primary outcome variable there? Is it something that we need to do a better job in the open label extension? I'd be interested from the panel and also anybody from industry if they could discuss that.
I don't think we know the answer. And when we're talking about Lennox-Gastaut syndrome, we're talking about improving on something that's already quite impaired. If I understand correctly, in the Epi-Stop trial, you were trying to get the development to continue on a good trajectory, right? So it's a little bit different, and we don't know. And if you would look at things like the NCL or SMA trials, those trials are geared to stopping degeneration of function. So we don't know. I mean, we know if we were to follow a typical child over 3 months, what to expect. Would we expect more than that? Is it like a switch that suddenly goes off? I'm going to guess probably not, but that might be like our upper level. But we don't know. And that's where natural history studies can come in. I think Michelle has a question.
Well, no, I actually had a couple comments before that question was asked, and actually ties in really nicely. So from what I've heard today, and this is, again, another comment that I think can benefit all, not just industry and FDA, but I think benefit all, is do we have the good, and as you continue doing all good science going forward, but I think would be helpful as we look at this conversation of when is it appropriate to start looking at non-seizure symptoms? Because really what we're talking about is a disease-modifying therapy. And that looks very different than a seizure trial, okay? And that's a whole different conversation. But I think what is helpful and what we know from other progressive diseases or diseases that have heterogeneity, and it changes over time, right? My experience at the beginning when things emerge shifts over time. And what is important to a family shifts over time as well. And I think it's important as we collect data in the natural history settings, observational studies, is as the child ages, what is really the main concern, right? Because it's going to shift. And I think that's informative of how much, perhaps what I've heard from different folks, parents that are here today, the varying abilities of perhaps their child to be mobile. It varies, right? I think those are the things that we need to capture to get a sense that this is the range we're going to see. We start seeing more emerging things around this time. And that helps a lot of different people. It can help maybe some of our more basic science research think about what's going on in the brain, or why certain areas are progressing over different things. We need to think about mechanistic things down the line for a drug. It can help us think about a study design that if we're going to enroll patients of a certain age range, maybe what are the things I should be measuring? So I think that would be beneficial, is what it really does longitudinally this looks like in a systematic way. I think it can help a lot of folks. My other comment is as we are collecting data, I encourage data sharing. I encourage prospectively putting in consent forms data sharing, because we fully believe that working together in research roundtables like this, or in the pre-competitive space, we believe data sharing is a very important aspect to that because it benefits the greater good. And so obviously, I think some folks in this room are aware that the FDA has funded something called the Rare Disease Cures Data and Analytics Platform. And they do have a good amount of various rare epilepsies. I know the TSC Alliance has been contributing some of their data as well to there as an example. And so I would think about that. How can we also give back to the science in the way to help advance future science is through data sharing. And so I would also encourage that. And like I said, I encourage prospectively adding it in, because we do know the challenges of when we think about it later and reconsenting and what will my IRB allow and things like that. We understand that too. So I think as we really explore these non-seizure symptoms in the rare epilepsies, where I know there's so many different similarities of the experience, but each individually, there are different experiences. And I think we need to have kind of like the playing field of like, what does that really look like? And I think that can help everyone in advancing science and research to help identify gaps.
Thank you. Any comments from the panel on that? Nope. Other questions?
Yeah, I have a couple questions, but first, really great job by all of you. I mean, it's just really nice to see all of you up there. I have such great respect for every single one of you, and it's just wonderful learning from you. I'm Anu Patel. Sorry, Tracy, I forgot to say. But my two questions are, what are your thoughts on borrowing from TSC and creating centers of excellence for LGS that require certain things to happen and do for kids who have LGS and their families? And Dravet has that, right? Like if we made that part of a center and then that helped inform, I would like your thoughts on that. And then the other question I have is survey fatigue. What do we do? Because we want to measure everything, and it's important to do that. We've heard that. But how do we balance that? Shush.
Anybody want to address the centers of excellence?
Well, I speak also from the CDCAR5 experience, where we have the Royal We have 8 clinics across the US, and it's only in the US, but it is extraordinarily valuable. And I think there's ways that could start small in terms of its scope, because it takes clinical time, it takes clinical effort. You mentioned it with the data management and storage. It takes a lot of thought to actually work that out well so it can deliver the results it wants to do. But it's a super idea, and it really makes sense. And it also makes sense because it connects clinicians up with the community in a much more tangible way. And I think then the challenge is to enable those learnings to go to families who can't get to clinics, because that geographical barrier is massive, particularly, well, in the United States, and of course it's bigger, right? It's rare diseases have a global community. So I think, it's a really great idea, but modest and little with all the right mechanisms for data management and then growing. CDCAL5, for example, I think had 8 centres at the time we put in for the grant, and it's now up to 10. It's slowly, they started with 1, Colorado back in 13 or 14, then another one and another one. It creeps slowly, and I think the idea is to have a vision and then a careful strategy in that regard. And I think there was one other thing, survey fatigue. I really don't know how to handle that. I think what we need is for us as researchers and anyone who's managing and analysing the data to be so responsible for those analyses and those outcomes, and to make sure that they are fed into the literature, they are fed back to the community so that it's really meaningful as to what happened when they put in that time after their really busy day, or had to log into a survey 5 times to get it done because they were disrupted every single time. So I think I tell families that what they give me is gold, and I want to demonstrate that. So that's the research community, the clinical community really needs to take that consumer idea of not without us but with us to every level of that journey. And I can't get rid of survey fatigue, but if we use it well, we can do the best with it.
I have some thoughts on that too. So I agree, everything Jenny said. I think we need to be really thoughtful, not just be giving surveys for giving surveys' sake, right? Having an empirical question. And then also thinking about incorporating feasibility assessment into when we are giving surveys to families, asking families, how long did this take you? How easy was this to fill out, right? So we're actually learning from families about the feasibility and the burden on them. And if we have better measures, I think that assess where a child is at, families are going to feel better about filling out those measures. And my hypothesis would be maybe a little bit more engaged and wanting to fill out and feeling good about filling out those measures, rather than it being like 0, 0, 0. This, this is really upsetting, right? So I think if we have measures that are a good fit, it's going to really reduce that burden, is my hypothesis.
I just want to add something to that, because that's exactly where my mind went. I wonder if it's just not fatigue, but like a lot of negative emotion, and people don't like doing things that make you feel bad. And so if you're filling out a form that you are reacting to emotionally, that contribute to that difficulty of filling out that form.
Can I add one more unpopular opinion, just to kind of enrich the spectrum of kind of opinions there? So I think Jim and I had this discussion earlier. So what we had in STX-BP1 was basically we didn't have any data. Yeah? And I think what we decided in July 1st is that we would go live with our natural history study no matter what. Yeah? And sometimes I think about that we tend to overthink these ideas about survey fatigue, and then my kind of very unpopular opinion would be, when it comes to survey fatigue, I would want to have less thinking and more doing. Yeah, so run into these problems. Survey fatigue is something that we can fix once it's there. Yeah, but if you have this problem, technically survey fatigue is a good problem to have.
I just wanted to mention, and Natasha, Jenny, you really emphasized the role of those of us who do the research, our responsibility, our obligation to share the information back. And I think those of you who've taken part in some of the natural history surveys and the ability studies saw that we did try to do that, including some of the parents from the groups that participated with us in writing the papers, but also presenting at meetings. We had the infographics, and we intended, just another pitch for the Inchstone survey, and I want to talk with you, Andy, about any difficulties you had with getting onto that. We do intend to return information in the form of webinars through the Deep Connections Network, and also written responses, written summaries back to the community. And we've also made
a somewhat ambitious commitment that any organization that recruits at least 20 people, that if we get 20 people, for example, from LGS, we'll do a customized reporting back to you. 20 was sort of the minimum where we thought we could actually give something meaningful for a group. So that's why it's not just give us 20, but that's where it might start to make sense.
So, Jim Wheelis, I had a comment to go back to Tracy's original question, which was, what can change things in the next few years? As there's currently, and there will be, I guess, ongoing new studies, and if these studies incorporate some of the things you guys have talked about, kind of, measurements beyond seizures, and they show that, okay, you know what, our seizure, response rate, our median reduction, our 50% response rate may be no different than, quote unquote, some of the already approved drugs, but if their other quality of life features are better, how do we translate that to the community? Because what I see in most of my colleagues is they really discount all of that almost. They kind of say like, oh, well, they're just saying that because they want to sell their pharmaceutical. We're looking at their seizure response rate. So how do we, if that is really there, how do we kind of get across how meaningful that is to families, what a score change, and then how do we communicate that in a way that clinicians will actually start to think about that with these products? Because that, I think, could be something quick to answer her question.
Any takers on that?
Arnold's going to answer it.
But I would like to extend on that because I've been listening to everything this morning, and I was telling Tracy this, during our last break, is that if we want to take a small incremental step forward, part of the problem with just including non-seizure endpoints is my trial, I might put these 3. Someone else's trial, they're going to put those 4. And we continue to do what we're doing where the companies are not assessing the same endpoints. So one of the things that I think we could do as a group, if you want to get a tangible outcome, is first identify what should be the LGS core set of non-seizure outcomes, even if it's just 2 or 3. And come to agreement on this is the best way to try and measure these 2 or 3 so that over the next set of trials, the companies that are doing these say, okay, if you have these 2 or 3 domains that you want as the core set, and this way we're all starting to measure them in a uniform way to answer the really important questions about the kinetics of how these domains move in relation to seizure frequency change. Is there any correlation at all with those? We've heard today how, a great improvement in seizures, but there's no impact at all on those. Well, that's important to know because if my pharmacology is geared at the seizures and there's absolutely no relation, I've just put myself in a situation where I might need a trial 5 times the size of what I would needed, 5 times the exposure to placebo. So that's why I don't like when I hear like primary endpoint. We're so far away from being able to put these as a primary endpoint in a trial, but I would like to see us at least make these incremental steps to start to answer some of the important questions. That's how I'd like to go on.
We'll ping pong back and forth. I was going to say, and then I would add to that, I would use the oncology model that if you develop 3 or 4 that are used for a couple studies, and then you guys come up from Inchstone, you say, wait a minute, we finally figured this out. If these aren't showing what we need to be seen, then you switch those out. You better ones. You keep pushing. You keep moving forward. You do the relentless pursuit of perfection model, and you keep pushing that until you get the exact one you need. Because we're so far away from that, it's ridiculous. I mean, it's embarrassing, literally.
I actually wanted to comment on that before you brought it up and go back to the work that Anne did several years ago about the state of the care in epilepsy compared to pediatric oncology, and that years ago she judged it as 30 years behind, and I suspect it's gotten worse. And it came up for me, I think he's gone, but when Anoop said, oh, the next step is replicate what TSC did for LGS. You all know there's 100 and growing number of DEEs. And we're not going to solve this one DEE at a time, even if you have 10,000. I mean, the solution, the strategic solution is we need to come together as a community, and it's really not easy to do that. but we need the comparable level of attention that pediatric oncology had, getting congressional support for that network. And that's where learn from every patient, get that common core data, but not just for LGS, because we've just got to get that data across the epilepsies and not anticipate that we're each going to build these centers, one bake sale at a time for groups that are run by parents who are caring for these kids. So we need a more systemic solution, and I guess to turn it into a question, Anne, where are we and what's the potential for a more transformative, innovative, and opportunity to learn and not just keep fracturing the centers of excellence or new measurements for each group?
Yeah, Jayetta, I'm an epidemiologist, not a population psychiatrist. I don't know. I mean, it is really complicated because everyone's in his own silo, has his or her own little domain, and I'm a little bit not so sanguine about that right now, but we do have to break through that barrier. In this country, I think one of the biggest barriers is that currently we don't have a healthcare system. We have a health billing industry, and that everyone is playing to that lower overlord. So I think you're probably right that we need to go through legal means to get things changed. But I know the EAN is working on that. I don't know if you're going to be. We have a 7 p.m. meeting about that tonight. So I'm only going to be at a short little bit of the reception, but there is an effort to do that, and that should include quality improvement. It should include centers of excellence, not just for a single kind of epilepsy, but for epilepsy in general. And I think we have to break it down between early onset DEEs versus the more adult model. Although I don't want to leave out the vast number of children who have things like childhood absence and benign, Beck's, it's no longer Beck's, it's Keck's, I guess. But, there is a lot of work to do. The other thing too, and I'm a little bit worried about saying this, a little nervous saying this at the LGS meeting, the founders of the really crappy seizure club, but everything is couched from the perspective of seizures. From seizures. And these disorders are so much more than that. And yes, I mean, the seizures are the daily disruptive, life-threatening manifestation of the disorder. But these are, TSC is not a seizure disorder, it's a multi-system disorder, right? You don't say this is a seizure disorder. You say this is TSC, and you might have lung and kidney and skin and eye and brain tumors and a whole host of other things. And that's a little bit uncomfortable for Lennox-Gastaut syndrome because it's a syndrome that's based on a whole set of disorders. So I don't quite know what the answer is. I'm going to start talking in circles. Someone else start talking.
Let me try to break the circle, maybe. Jed, I think what we've seen in the DEE space is actually quite interesting. So we had epilepsy, we had infantile spasms, West syndrome, Lennox-Gastaut syndrome. We had genetic diagnosis. It kind of fell into hundreds of different DEs, and now we're coming back together again. And I think I just want people to kind of appreciate this momentum, that this is actually happening. Yeah? And I think, coming back to this first question, what can we do? I would maybe leave this with a more abstract thing, is to try to understand the energy of the moment. Yeah? What is kind of currently happening? There's very big energy and momentum in the monogenic rare disease space. Let's capture this as much as we can. Let's make sure that every kid with Lennox-Gastaut has had genetic testing as early as possible. Because I know that there are probably 500 kids out there in the US with STXBP1 or CDKL5 or SCN2A who don't have a diagnosis yet. This kind of inches you a little bit forward. And then kind of understand where does this kind of leave us with kind of LGS. I think what we kind of take away from this kind of thought process is that there is, that making meaningful subgroups doesn't necessarily fracture. It may inform this. I think one problem that we've always had in the LGS field is that it is a very heterogeneous conditions when we kind of often use the same word for different things when we talk about comorbidities. And I think just kind of learning from what is happening in the field is the one thing that I think is really possible right now.
I think he's first. I just wanted to kind of amplify what Anne touched on, which is the fact that we're, I think, all kind of collective victims of the healthcare system that we're functioning within, you know? And it's kind of, in some ways, unanimously agreed upon, I think, by everybody in the room about how poorly it serves the patients, for sure, but also how poorly it serves the clinicians who are trying to help the patients. And we're kind of like all frogs in the, you know, in the boiler as the temperature gets hotter and hotter until something happens. And so, you know, I feel like as, you know, I've been struck over the years by how effective a handful of highly motivated parents can be, and far be it from me to, you know, put anything else onto the agenda or the list or whatever, but like, I can just imagine the powerful moms who spoke today on Capitol Hill marching down the halls of Congress with their kids. Like, holy crap, what are they gonna do? You know, they will run in terror. So, yeah, I mean, it'll make January 6th look like a cakewalk, you know? I mean, it's just incredibly powerful. So there's advocacy to be done. I think the fundamental problem with all of the things that we've talked about is the mismatch between where the value is for patients and families and where the value is paid for in the healthcare system, right? If you can make those two things match, you don't need to do anything else because the system fixes itself because that's what gets paid, right? You don't need a center of excellence for you know, this type of epilepsy because you're paying for the good things that happen in that form of epilepsy, and so it's gonna happen because that's what gets the hospitals paid. And I wanna, you know, kind of simultaneously give just the biggest amount of respect and gratitude to Ingo, who is, you know, generating just an incredible data set of natural history, you know, from nothing. You're getting no support directly to get that done. You're, you know, cobbling it together yourself to make it happen, but that is just unimaginably hard. The same thing for Anoop, doing quality improvement and like trying to make the system work better. So hard, and here we are telling them, you know, here's what else we need and here's how else we can look at it. And these folks are really happy to do that, but it's a little bit like telling your attorney, like, I'm innocent, I really don't deserve, you know, these are your advocates. And so let's all advocate together to the people who really are pulling the strings for all of us, you know? And I feel like right now, Mitch McConnell is super receptive to the idea that seizure control and seizure treatments are useful.
Dr. Rao.
Hi, Satish Rao, Takeda Pharmaceuticals. Dr. Wirrell, is it okay if I take us a little off topic to EEG for a moment?
Sure.
Okay. So, Dr. Helbig, I noticed on your QEEG slide you had my favorite montage, the Laplacian. Was that, this is just a detail, then I have a more broad question. Was that intentional? Is QEEG best based off of a Laplacian versus a referential or bipolar?
No, this was just a stock photo.
Okay, I was thinking that, but now it's confirmed. So but it leads to the bigger question, which is back to this morning's discussion. If we were to put EEG as a secondary outcome, what do you all think about just leapfrogging to quantitative EEG and not doing the traditional human-based review for reliability, labor, or is that just too much of a leap? I don't know the answer. I'm just totally curious.
So I think it would be good to phrase this question very exactly. So I think this is a question we can say, what would I do for a 12-year-old with LGS? What we're using quantitative EEG for is basically look at markers that typically would not show on a normal EEG. So many of our STXs, they have emetal spasms, but then they have an EEG that doesn't show any focal features. This is where we try to look at markers that are quantitative that we can suss out. For Lennox-Gastaut, I would defer to the experts in the Lennox-Gastaut EEG field, but given that we have such a, let's say, prominent EEG feature, you can probably use this as a primary marker in the same way that you can do this with like generalized epilepsies. And then you can add quantitative measures on, but they will probably influence each other.
Any other comments from the group? All right. So I think we are almost out of time. I think we may have time for one more question or final wrap up from Tracy.
Any other questions?
Thank you very much.